Now we know all the etiological factors responsible for hyperbilirubinemia. Let's quickly recap all the congenital hyperbilirubinemia. Starting off with congenital defect, where genetic mutation takes place such that there is impaired uptake of unconjugated bilirubin from blood circulation into hepatocyte. As a result, there is accumulation of unconjugated bilirubin in blood circulation, leading to unconjugated hyperbilirubinemia. And this condition is seen in which syndrome? It is seen in Gilbert syndrome. Okay, so that's the first congenital defect or genetic defect. Second is a genetic defect that leads to deficient production of glucuronosyl transferase. Glucuronosyl transferase is responsible for the process of conjugation. So if there is deficiency in glucuronosyl transferase, conjugation will not take place, leading to accumulation of unconjugated bilirubin and unconjugated hyperbilirubinemia as well. Now, there is three types of deficiency that can take place. Either the deficiency is mild, the genetic mutation is not that strong, or there is partial deficiency, or there is the worst of the worst, complete deficiency of glucuronosyl transferase. The question is, in which particular syndrome are such deficiencies seen? Mild deficiency is seen in Gilbert syndrome. Partial deficiency is seen in Crigler, I repeat, Crigler-Najjar syndrome. However, it is of two types, type 1 and type 2. This is seen in Crigler-Najjar syndrome type 2. Complete deficiency is seen in Crigler-Najjar syndrome 1. So 1 is much worse. Since in Gilbert syndrome, there is mild deficiency, so the condition is mostly asymptomatic. But there are special conditions where symptoms manifest, and they are, so the symptoms manifests in stress, fever, and pregnancy. When there is partial deficiency, as seen in Crigler-Najjar syndrome 2, phenobarbital can be used as drug therapy, because phenobarbital, it increases the production of glucuronosyl transferase in baby. Crigler-Najjar syndrome type 1, since there is complete deficiency of glucuronosyl transferase, absolutely no conjugation takes place, there is overload of unconjugated bilirubin in blood. So this is 100% fatal. The child, the baby does not survive. All right. So up to here, the congenital hyperbilirubinemia are unconjugated hyperbilirubinemia or congenital unconjugated hyperbilirubinemia. Next. So next is there is reduction or impaired reuptake. The reason behind it is, see, reuptake of the leaked conjugated bilirubin from portal circulation back into hepatocyte takes place with the help of transporter OAT 1B1 and 1B3. Mutation in transporter OAT 1B1 and 1B3 causes impaired reuptake, and such mutation is seen in which syndrome? Come on. Gilbert? No, it is seen in Rotor syndrome. How can you remember? See, O for OAT, and there are two O's in Rotor syndrome as well. And finally, there is impaired secretion. After the production of conjugated bilirubin in hepatocyte, it gets secreted into biliary canaliculi with the help of transporter multi-drug resistant protein 2. Mutation in multi-drug resistant protein 2 leads to impairment in secretion. As a result, accumulation of conjugated bilirubin in hepatocyte takes place and it gets pushed back into blood circulation. Such mutation is seen in Dubin Johnson syndrome. So both Rotor syndrome and Dubin-Johnson syndrome causes conjugated hyperbilirubinemia. Both of them cause conjugated hyperbilirubinemia. The difference, what's the difference between the two? The difference is that in case of Dubin-Johnson syndrome, the liver, it becomes black. The reason is accumulation of metabolite of catecholamines in the liver in this particular syndrome. When a baby has Dubin-Johnson syndrome, the catecholamine metabolites, they get deposited in the liver, and these metabolites give black pigmentation to the liver, so the liver appears dark.